Okay, thank you everyone for coming. We're gonna get started with today's panel. So this is the last panel in a series titled Conversations in Diversity about hidden disabilities. And each Thursday this month, we have discussed an invisible illness. And we've chosen to do this to explain that the umbrella of diversity, equity, and inclusion goes beyond and is broader than gender and race. Hidden disabilities affect about 60 million people in the US, and it's quite possible that you know someone who's been diagnosed with these illnesses or is something that you've dealt with yourself. We have covered so far ADHD and autism, diabetes and hypertension, and mental illness, and today's topic is long COVID. Each week, our panelists have included a researcher, medical practitioners, and someone who deals with the topic personally. We have primarily chosen panelists from within Vanderbilt, both the university and the medical center, to foster community building. And although we will be discussing medical conditions, please note that we are not dispensing medical advice. And we will be discussing this from a research perspective and from our panelists' personal experiences. So I'd like to begin this conversation with panelist introductions and with my introduction, which I forgot to do. My name is Aaron Conley. I'm the Director of External Affairs and Partnerships for the School of Medicine Basic Sciences. I'm standing in for Felicia Jenkins, our Program Manager in Diversity, Equity, and Inclusion, who is here online, but is at a conference in the lobby of a hotel that is rather loud. And so I will be moderating today. And so am pleased to have our panelists introduce themselves. We're going to start with Dr. Chabot, then Dr. Martin, and then we have Dr. Goltz joining us online. So Dr. Chabot.
Thank you, and thank you for the invitation to participate in this meeting. So my name is Cynthia Chabot. I am an associate professor of medicine and the associate director of the Autonomic Dysfunction Center. In terms of my experience with long COVID, we run a long COVID autonomic dysfunction clinic at Vanderbilt. And in addition to that, I'm a scientist and I'm currently the PI of a study that is looking at inflammation and autonomic dysfunction and the use of vagus nerve stimulation. This study was funded by the American Heart Association.
Hi, I'm Sarah Martin. I'm an assistant professor of medicine here at Vanderbilt. I'm an internist and actually a palliative care physician. And I actually was part of the effort to create and stand up the post-acute COVID clinic here at Vanderbilt. And I'm now the medical director for the adult post-acute COVID clinic here at Vanderbilt and see patients that have post-acute sequelae of COVID in that clinic.
And Dr. Goltz online.
Hi, my name is Heather Goltz. I'm a professor of social work at the University of Houston downtown. I'm both a clinician and a researcher. And my mainstay is cancer. However, I trained and studied and have done research in infectious disease. Today, I'll be providing, however, more of a personal and professional perspective.
Thank you, Dr. Goltz. So we just want to start with a broad overview question for Dr. Chabot and Dr. Martin. And if you want to chime in, Dr. Goltz, please do so. Just what is long COVID? What is its definition?
I guess I'll go first. There's no formal or there's multiple competing definitions. If you've looked at the literature, there's multiple terms for long COVID. So there's long COVID, there's post-acute sequelae of COVID, there's long haulers, there's multiple names. Generally speaking, it is an illness that persists after an infection with acute COVID for longer than 3 months, and that there's no other cause that we can identify. So really it is a diagnosis of exclusion, if you want to think of it that way, but you have to have had either diagnosed or probable acute COVID and then have persistent symptoms after resolution of that acute infection.
So one of the major challenge in the diagnosis of long COVID is that, you may have a patient that has severe COVID, was admitted into the MICU, had a very difficult, clinical course, and then now he's discharged and he has persistent symptoms. or you can have a young individual who didn't have a severe COVID infection, who didn't have any significant symptoms, and yet after the acute infection, they start having these persistent, symptoms that are very, affecting different type of systems, cognitive dysfunction, autonomic dysfunction, exercise intolerance, so forth. So, and both of these presentations are grouped under the same definition. So it's very, very difficult to diagnose these patients and try to classify what caused the persistent symptoms, either the illness or the treatment, or the viral infection itself.
And I would just add, if you've ever seen any studies of symptoms that can present as post-acute sequelae of COVID, it is every organ system. Every organ system can have a symptom that could be attributable to long COVID.
Very much. Dr. Gold, did you want to add anything about this is the mic up here that's picking. Can you hear me, Dr. Gold? Can you hear me now? Awesome. I'll stand over here. The IT guy said this doesn't go through Zoom, but I guess it gets picked up. Dr. Goltz, did you have anything to add about just the definition of long COVID or your personal experience of what that definition is?
Sure, and it's a great question. I'll add to my colleagues that long COVID can not only is not that it can impact any organ system, and it has a very diverse presentation, but it can also include people who have exacerbation of existing illnesses that may have been well managed medically prior to COVID, and that then become have increased severity and frequency post infection.
Thank you very much. And so what is the prevalence of long COVID? How many people are generally diagnosed? Do we even have these statistics yet with how new it is?
I'll go again. Yes and no. So we have estimates of prevalence. It depends on what study you read. There are some studies that estimate the prevalence as high as 50%, which is a little bit startling, and I certainly hope not. There's data from the CDC looking at US census data that shows a prevalence of around 15 to 18% of people that had acute COVID or presumed acute COVID having at least one symptom of post-acute sequelae of COVID. So really you could find a prevalence ranging anywhere from about 3 to 50 or higher, depending on what study you look at.
In our clinic, we focus on a specific subtype of long COVID. These are usually young women that were previously healthy, that after COVID, they present with orthostatic tachycardia, which is an increase in the heart rate upon standing, syncope, exercise intolerance. We call that part of the autonomic dysfunction, sort of, symptoms that these patients present. And we have seen this presentation in about 10 to 15% of patients that have COVID, and now they are diagnosed with long COVID. But this is just a subtype that is just mostly focused on autonomic dysfunction. There is, as Dr. Martin said, there is no a very good study to estimate the prevalence because the symptoms are so unspecific and involve multiple systems. The only study that I remember that was published was a study in which the patient actually reported COVID, but then they went back and looked at whether the patient actually have a positive COVID infection with PCR. And I found that was a very interesting study because they were reporting symptoms associated with COVID, but really, there was no recollection of a COVID infection. And those who have the reporting of system plus a COVID positive infection, the prevalence was about 60% versus 40% that said I had COVID and I had long COVID, but they didn't have any positive test. So So I thought that that was very important in the sense that there is a lot of bias in terms of, when you get the infection, whether these symptoms are persistent, really related to the infection or not. A lot of, recall bias in this regard. And that study sort of, try to address that.
Thank you very much. Dr. Goltz, anything to add to the prevalence question?
I primarily work with cancer diagnosed populations, so cancer patients and survivors. What we are seeing, and of course it varies, is complications of the treatment regimen and reduced functioning and quality of life of survivors post-COVID infection. But in terms of long COVID, it's difficult to tell, particularly when you've had folks who may have overlapping symptoms that also are common to radiation or chemotherapy or other types of cancer treatment. So, the answer really is in progress. I suspect we're going to learn more over the coming years, just like we are with young women and other folks who are suspected of or diagnosed with long COVID.
So how are people diagnosed? What does that commonly look like for someone who thinks they have long COVID? How do they get diagnosed with long COVID?
Well, first of all, you need to be sure that you have COVID, because a lot of what we sometimes see is patients that feel they have the symptoms, but they never were tested, or they have, antibody testing. So, and because they have the symptoms and they have these tests, and after this sort of acute infection that was never confirmed, then they start having all these residual or persistent symptoms. So the first thing is always, be sure that you have COVID, that it was a very good test, that you have the clinical presentation, or that you have a mild illness, and not a severe one, but you still is associated with the presence of the infection. The other thing is the persistent part. So if you have a positive COVID infection, there is a period of convalescence, which is about 4 weeks after the infection. And then if you have symptoms, persistent symptoms after this 4-week period, and you can prove there is chronicity, in other words, at least for 3 months, then definitely that's something that you can say, well, is within the definition of long COVID, right? So one of the things that I always add to that, and this is from my clinical experiences, the question is, are these symptoms really disabling to the point that, we need to intervene and then start treatment? And that's a very important question, because at least the population that I see in my clinic, there are young, healthy, individuals, and they do have symptoms, but a lot of the medications that we use and interventions are really, we implement chronic interventions such as medications to slow down your heart rate or to prevent syncope. So that's the other component that I usually try to address in my clinic. Yes, you have persistent symptoms, you have a positive COVID test, and you have it for this amount of time. What will be the next step? Are you really, is really affecting your life that much that we need to intervene and start with all these, chronic treatment in a person that is very young, that have to take medication almost on a daily basis?
I would add, so the best definition I've seen is from the World Health Organization, and it lists 4 criteria, which Dr. Chabal just covered most of them, but it's a history of known or probable COVID infection. I think it's still important to say probable. If you remember at the beginning of the pandemic, it was actually pretty hard to get your hands on a COVID test. So we do see patients that really believe that they probably had COVID, maybe January, February, March, April, 2021. And they just could not access a test to get that positive test at that time. And then you need to have symptoms 3 months after that diagnosis. So again, the persistence, and for at least 2 months. So you have to have ongoing symptoms, and it has to occur after that period of convalescence. So You can have symptoms from acute COVID for, we would say, 4 to 6 weeks after your diagnosis. And it's not until at least that 6 to 8 week mark that we would say that it's chronic and moving into more of the long COVID spectrum. And then most importantly for us, when we're seeing these people in the internal medicine arm in our clinic, is making sure that you don't have another diagnosis that could explain these symptoms. So to Dr. Goltz's point, maybe you had asthma, and now your asthma is really quite difficult to control. And that might be because of side effects of COVID or what COVID, did in your lungs, but we wouldn't necessarily call that long COVID. We would want you to get better control of your asthma. So we're making sure that someone doesn't have either a previous condition that's now exacerbated or a new condition that we need to treat before we diagnose them as having long haulers.
Thank you very much. And Dr. Goltz, wanted to shift a little bit. How can the symptoms and impacts of long COVID affect someone either as a student in their research or education, or for someone who's a staff member somewhere, either in higher ed or elsewhere? How does that impact your work or your education or research?
Oh, go ahead.
Go ahead.
It's an excellent question. And of course, a lot of it depends on the symptomology and how long COVID manifests in comparison to what are perhaps the cognitive or sensory motor demands of your faculty or your staff position, or even what you're studying and the demands as a student. I'll start with, faculty and staff. And I'll use myself as an example. I'm a faculty member because I live, the glorious life of the mind, as you will. What happens between my ears, my brain, is my most valuable tool and asset as a clinician and a researcher. I will say that and disclose that I had ADHD diagnosis prior to COVID. But in many other ways, other than, being an approaching middle-aged Black female in America, in many ways, a lot of my history was not that remarkable, other than me being a cancer survivor. And so for me, after that period of convalescence, increasingly I noticed, difficulty calling words, common words, even when I was looking at them, basic words. And, having, the brain fog that everyone talks about, and also this relaxing and remitting fatigue. Now, of course, I'm a very busy faculty member, and I'm, and a clinician. And so what part of that fatigue was perhaps due to long working hours and lots of rigorous deadlines and whatnot. It took me and my physician several months, actually, to parse that out, inclusive of even lab tests and physical exams, etc. And so, with faculty, particularly when it comes to, attending to deadlines, your writing and other communication skills, these are ways that this could be impacted just as much as with staff if they have to lift or climb or walk or critically analyze legal documents or other aspects of their work that can be impacted. And certainly, I've had a number of students who, due to fatigue or the brain fog, and just among themselves, or even serving as caregivers for children or other relatives, impacted their ability to adhere to deadlines with their studies, to be able to successfully follow and complete instructions on assignments, and so on. And that doesn't even include some of the physical symptoms that my esteemed colleagues have discussed in terms of cardiovascular health and other. So I'll stop there.
I would just say it's important to know when we look at the most common reported symptoms of people with post-acute sequelae of COVID or long COVID, the number one things tend to be shortness of breath, which you can imagine that might be pretty debilitating if you had to be on your feet or work a lot. Cognitive impairment or brain fog. So, and that can be minor. So it can be, I just have a hard time focusing on this task, which we would say is, quote, minor to very severe cognitive impairment. Post-exertional fatigue or malaise. So we see patients very commonly that feel pretty good, go do a normal day, and then they're in a bed for the next day or so. And that can be incredibly debilitating and hard for colleagues and others to understand. Like, you were just at work and you seemed fine, and now you're saying you can't be at work. So those are some of the top 3 that we're seeing when we're seeing these patients. We certainly see cardiac complaints, autonomic complaints, but they tend to be much more subjective: shortness of breath, the cognitive impairment, brain fog, and the post-exertional malaise.
So from the autonomic perspective, the typical symptoms of these patients is, once again, rapid heartbeat, usually worse in the morning when the patients stand up still without moving, that improve after the patient lay down. These changes are associated with dizziness, lightheadedness, feelings of fainting, sometimes blurred vision, sweating, or increased warm sensation. So these patients have these symptoms chronically, usually every single day. Sometimes it's associated with what we call vasovagal syncope, which is a fainting or common fainting. And it really disrupts their daily activities, because of course, you cannot stand up for longer than 10 minutes when you have this postural tachycardia. Some of the things that we recommend, and sometimes we have to communicate with employers, is the fact that this patient needs to be very well hydrated. So they need some time to recover and hydrate themselves. That sometimes it will be better when they have a lot of symptoms to do work where they are seated instead of standing for a prolonged period of time. We also recommend not to operate heavy machinery, particularly those who have history of these vasovagal syncope or fainting. So those are, sort of, the basics in terms of changes in their workspace and the activity levels of these patients. And we, we have seen these patients with postural tachycardia syndrome before COVID, and now we're seeing them very often in some of these long COVID patients, not all of them. And those are, once again, the recommendations that we provide to them.
So Dr. Chabot, you brought up accommodations in the workplace that could be necessary. And that was actually my next question. So thank you for leading us into this discussion. What are some of the main accommodations that individuals with long COVID can request potentially in their workplace?
So I think everything depends on what is the primary symptom, right? In my case, like I said before, I see mostly presyncopal symptoms and orthostatic tachycardia, and the recommendations are based on what we usually recommend in our usual population of postural tachycardia syndrome that are not associated with COVID. And I just outlined them before. So frequent breaks, very well hydration, stops, try not to stand up for a prolonged period of time, if possible, especially at the peak of your symptoms, because these symptoms wax and wane. And when they are very severe, that's what you have to do. Abdominal binders or compression stockings or compression leggings is another thing that you may want to use if you have all these symptoms. And once again, you have to protect yourself and protect others. And if you are having an episode where you're very symptomatic and you have multiple episodes of fainting, stop driving, and do not operate, like I said before, heavy machinery. For the other patients that have cognitive dysfunction, well, I'm not an expert on that. My understanding is that there should be some type of accommodation, especially for a student. But once again, I'm just speculating.
Dr. Goltz, do you have thoughts on those other accommodations?
Absolutely. So for students, they would be able to work through their university or community college's Office of Disability Services or equivalent They can furnish documentation from therapists, psychologists, physicians, and work with the staff of an Office of Disability Services to receive a range of accommodations based on diagnosis and needs, whether those would be note takers, transcribers, additional testing time, or time to complete assignments. So there's a range of things that can happen through Office of Disability Services. Additionally, Title IX office can assist with students who are pregnant, parenting, etc., in terms of working with the students' faculty to be able to bring in additional accommodations related to their courses. In terms of faculty, staff, employees in general, the American Disabilities Act certainly allows for a range of accommodations through completing forms and providing documentation from some of the aforementioned providers in terms of work accommodations in that way. And additionally, there's also the FMLA that may provide partial time or full-time, usually unpaid leave. FMLA is unpaid, but some universities and organizations do actually provide pay when someone takes FMLA, but unpaid time to be able to take time for illness and care of others, etc.
Wonderful.
So
Thank
those
you.
are just a few examples.
Thank you for that. Those are great examples. And with accommodations for individuals with long COVID, are there items people should consider before disclosing their status with long COVID or requesting accommodations? And that question's for anyone, but Dr. Goltz, I don't know if you want to start.
You know, long COVID, just like, you know, a lot of other complex conditions or chronic conditions, people should think very carefully about who they disclose to and the need to know of the party concerned. It is a good practice, whether it's long COVID or other complex or chronic conditions, to have your documentation from your providers and to talk with your HR. At my university, it's employee operations, basically. But to begin that discussion with, you know, in safe space, confidentially, and to explore the options one has and the potential for accommodations, and then looping one supervisor in once you have a sense of what the options may be. You know, unfortunately, we have a rich history of stigmatizing you know, folks who have emerging or diagnosed differences in abilities. And, you know, at least with long COVID, I suspect that it's going to be very similar in that case. I would treat this information, and I would tell any of my clients or patients, you know, this is need to know information until one can establish what one's rights are as an employee and what protections may be available.
I think that's so helpful, and to really understand the stigma of chronic conditions and how that can affect disclosing that is so important. And that kind of brings me to another question, which anyone can answer, is around, can people be successful in the workforce or in their education with long COVID with stigma on chronic conditions like this?
Yes, I mean, I think that, and once again, I mean, this is based on my experience in my clinic. I see a lot of our patients that are very scared about the diagnosis of long COVID because they don't know what to expect. And one part of an important part of what we do as a clinician is to provide reassurance, because most of the evaluations that these patients have, and they have a lot of evaluation. I mean, they have seen sometimes multiple providers. There are all of them normal, but they still have the symptoms. So reassurance that, this is a condition that hasn't created any life-threatening situation because, all the evaluations so far have been normal is the first step. The second step is that when you have a case like that, you need to discuss whether the treatment that you're going to implement are going to be either curative or they're going to go after the symptoms. And the majority of the treatment that we have in our clinic are mostly to control the symptoms. And therefore, when we establish a plan of care, we never do the type of treatment where you ask the patient, for example, to take a medication 3 times a day. Because, this treatment is focused on diminishing the symptoms. And the symptoms usually occur when the patient is active. So we encourage them to, if they need to take medication, to take it on as needed basis, to focus a lot on exercise, dietary modification, use of compression garment, abdominal binders, and then also to be sure that we validate what they are telling us in terms of what are their sufferings, because that's the other important piece of in the treatment of these patients, that you don't want to tell these patients that everything is normal. So probably everything is in your head. So that's the worst thing that you can do. You need to validate the symptoms, reassure the patient, establish a plan of care, and establish expectations in terms of whether it's going to be symptomatic improvement versus curative.
Yeah, I would echo what Dr. Chabal said. So we see patients in consultation, and often when we see them, they've seen many providers before they see us and have had many studies often. And again, generally reassuring, but not necessarily reassuring to the patient because they still have the symptom. So we certainly do see people that are successful in the workplace. Sometimes their success looks different than what it looked like prior to this diagnosis. So one thing Dr. Chabal and I were talking about before this is a lot of what we're doing for patients revolves around counseling and acceptance therapy, and really trying to come to terms with their new quality of life, if you want to think of it that way, which can continue to improve over time. We do see patients get better, but I have to tell everyone time is relative. So for some patients, that's 6 months and they feel a lot better. And then we've certainly seen patients it's over a year and they do not feel a lot better yet. And so we can't yet tell you how long it will take you to feel better, but we do think over time, ideally, you will start to feel better.
So if someone believes they have long COVID, what is the best way for them to get diagnosed and to receive the best possible treatment?
The best way to get diagnosed is, I mean, we would recommend that you start with your primary care physician. So ideally you have a primary care physician and you can go in and say, these are the symptoms I'm experiencing. I had COVID and I'm really worried that maybe it's related to long COVID. A good primary care physician can do a basic workup to ensure that there's not something else reversible going on. And then I think if you become really concerned, it is worthwhile to try and get into some sort of long COVID clinic, just because we have the expertise and all these specialists available for whatever potential symptom or problem that you're having, including things that you may not think about. So some things unique to Vanderbilt, we have cognitive therapy here. So we've partnered with speech pathologist and Pi Beta Phi. So we have dedicated cognitive therapy for people that have brain fog. We also have cognitive support groups. So for patients and families. So those are support groups dedicated to people that have persistent cognitive impairment or brain fog. And a lot of what those support groups are doing, again, is more of that acceptance therapy as well as some cognitive work, rehab. And we also offer different physical therapies. So, As I mentioned, post-exertional fatigue is one of the more common problems. So we actually have worked with physical therapists to develop a physical therapy program for patients that suffer specifically with that problem. So if I sent you to a quote normal physical therapy session, they'd probably work you out really hard. You'd do super great, and then you'd feel terrible, and it wouldn't work out and wouldn't do what we were hoping. We also offer diaphragmatic breathing technique for people with persistent shortness of breath. So there's all types of things that we can do. None of them necessarily quote curative and not necessarily a medicine, which can be frustrating for patients. But big COVID centers do have treatment options.
Thank you very much. And this next question is for everyone. What do you think the future looks like for long COVID research and for people suffering from long COVID?
I can address a question about research. When we started doing research in long COVID, one of the main challenge is that it's very difficult to sort of not only ascertain the diagnosis, but also think about the type of patients that you are going to enroll in your clinical trial. Because like I said before, you can have this wide range of presentation, patients who have, significant disease and were admitted in the MICU, and patients that were previously healthy without any significant illness, COVID illness. So that was a big challenge. So the way we approach this, and this was based on a call from the American Heart Association to study mechanism in long COVID, is by focusing on an area, on a subtype of patients with COVID that we learn, that we know very well based on our experience doing studies in patients with autonomic disorders without COVID. So when we submit our proposal, we were focused on patients with long COVID and persistent tachycardia or orthostatic tachycardia syndrome. And the inclusion-exclusion criteria of the study was very specific in trying not to enroll patients who have previous illness. And this is not because we don't want to treat these patients, but it's because we are addressing mechanisms. So there are different type of research proposals in this area, ones that really are focused on ameliorating the symptoms, and the other ones are on the pathophysiology of the potential pathophysiology of long COVID. For the American Heart Association mechanism, we decided to do a mechanistic study. One of the things that we did, thanks to the collaboration with the long COVID clinic, is we look at all the patients that were evaluated in the clinic with long COVID POTS versus our normal controls, and found out that some of these patients has impaired parasympathetic activity, and therefore, based on that, we design a clinical trial to evaluate a vagus nerve stimulation for 4 weeks in these patients. So using outcomes that are really mechanistic, not clinical. Now, the studies are coming, and I can mention a couple of words about that from the RECOVER trial. And I am one of the members of the steering committee, are focused more on treatment. They don't care that much about mechanism, they want treatment. And therefore, some of the efforts that are being made are focused on trying to identify different treatment strategies and moving forward on a clinical trials type of scenario. And these are the studies that have been proposed in the most recent committees for the RECOVER effort at NIH.
I would just say generally it's wide open. So the research field is wide open and there's a lot of excitement. So, RECOVER, as Dr. Chabal mentioned, is the big NIH funded grant, and that has both clinical trials as well as electronic health record data trials going on, which Vanderbilt is one of the sites for the EHR part, which I work on. But there are trials coming for actual treatments, which is new. There's still trials ongoing around pathophysiology. So there's a lot of research in this space and more that will continue to happen.
And industry also jump in. So we have at least one clinical trial ongoing with an immunomodulator in patients with long COVID. And part of the effort at RECOVER is to identify the domains. So the subtypes that you're going to study based on the clinical observation. So there is a domain for exercise intolerance, for fatigue, for brain fogginess, for autonomic dysfunction. So they're trying to, to focus on different domains because it's so hard to really enroll these patients because, you have so much heterogeneity in the type of population that you are recruiting.
And Dr. Goltz, did you have anything to add around the future of research or future for individuals who are suffering from long COVID?
Yeah, I think it's important to recognize that it's a really human response to fear and uncertainty for your future, to recognize that you are changing from your pre-COVID baseline, cognitively and in physiologically, physically, and many other ways. And so part of treating the symptoms of long COVID, as has been mentioned, needs to be very holistic. And not just to treat the long COVID symptoms themselves, but often the fear, the worry, the anxiety, and even the depression that can come from these changes that you recognize, and helping to cope with this new normal that may eventually go away or may be permanent, in fact, changes. And so support groups, therapy, even for one's caregivers or one's partners or family members may be warranted, depending on, just how much one's changed in terms of functioning and how much this may bother the person who's been diagnosed. I would add that given historic differences in access to care, one of the things, in terms of getting diagnosed, it, presumes that one does have a primary care provider and a relationship. Certainly someone like me benefited from having well over almost a decade and a half relationship with a primary care provider and some other specialists before I had COVID, but I'm not a typical person in that regard. And so encouraging, medical homes, working healthcare systems, working with the public health infrastructure in their area to try to make sure that folks, regardless of their socioeconomic status, have access to primary care are all ways that we build up the infrastructure to help people to have access to care broadly, but specifically to have access to care for potential long COVID.
Thank you very much. And our last question is really around how can we be allies to peers of ours that have long COVID or just long COVID sufferers in general?
I think the biggest thing is what we've already mentioned is validating if they choose to disclose that, or if you see someone and you think, gosh, they seemed fine, now they're not fine, not assuming that they're making it up. So this is a real illness. It has been designated even eligible for permanent disability, not just short-term disability. So I think recognizing that people truly are suffering and that you may not know all of their story is probably the biggest thing you can do in the workplace.
Well, I totally agree. So if we put in parallel what happened with, for example, POTS, that is an autonomic disorder, patients, they look healthy. They have all normal, sometimes testing or evaluation for different systems, but they just feel bad in terms of, these chronic illnesses. And that's important because you don't want to dismiss or not to recognize the symptoms that these patients have, because that can be very disheartening. And not only to a colleague, but to your patient, right? Because some of these patients, once again, they don't want to get sick. They don't want to go to the doctor. They just feel that they have to because, all these different problems that they experience.
Dr. Goltz, any final words on how to be an ally?
Beyond just the interpersonal relationships, I really think that those of us in practice and research and need to really be talking with our policymakers. I don't think that our current infrastructure or policy are prepared, particularly in the realm of long-term disability. I don't think that we're prepared socially, politically, economically, etc., for a potential onslaught of people who may have very valid, real, meaningful treatment needs, and not with an eye towards cure, as my colleagues have stated, but even symptom management and how that may change their occupational or their social or economic outlook. I don't think we have the infrastructure yet for that, and I think we do need to be prepared for it. So allyship can also take a more organizational outlook, but it also needs a more community and wider society outlook in terms of how can we ally.
Thank you all so much for these very thoughtful answers. I just want to see if there's any questions from the audience before we conclude our panel today.
I don't know that we have any data that says we'll see increased rates of cancer, particularly related to long COVID at this time. So we don't entirely understand the complete pathophysiology. Is there more inflammation? Yes. Is there a viral reservoir? Probably. So we don't entirely understand exactly what is causing long COVID to say that that then also caused another disease. We certainly are seeing, because I do work in palliative care and cancer clinic, delayed diagnosis from the pandemic.
So the question was related to, does chronic inflammation of long COVID help increase the rates of cancer that could be caused from that? As someone who focuses on cancer, Heather, Dr. Goltz, do you have any thoughts on that?
Yeah, that's going to really require long-term epidemiological study. And even then, depending on how the study is designed, it could only give us correlation, associations, not causality. That's going to take the work of a number of researchers across a number of fields working together to look for not just mechanisms, but causality between long, COVID infection and something like cancer, which requires study of many genes and gene environment interaction, among other things, to trigger, a cancer. So the answer is we'll see.
Any other questions? Yes.
I guess I'm thinking about how a lot of the symptoms are, how do we get like that as a whole?
And let me repeat the question real quick so that Dr. Goltz can hear. So the question was related to sometimes these symptoms feeling subjective to the larger population and the potential for imposter syndrome around, am I actually feeling this? Or am I just, especially as a student, am I just struggling to keep up because I'm not actually as good as my peers, et cetera?
So I will say what I say to each of my students at the beginning of every semester. It's not for your instructor or your peers to diagnose you. If you believe that something is impairing your ability or affecting your ability to perform in courses successfully, meet with the Office of Disability Services, talk with them, get their guidance on who you might speak with to obtain testing, diagnosis, documentation, and work with your Office of Disability Services to determine if accommodations need to be made, and then to work with the faculty to assist you in successfully securing accommodations.
Well, I mean, all symptoms are subjective. So if you really, I mean, if you develop all these symptoms and there is a time association with infection, which is, what we describe as part of the definition of COVID, and it's impair your ability to perform, you need an evaluation. And according to our evaluation, then we will put you on a treatment plan or not, or do a lot of validation, reassurance, and coaching, and see what is the progress of the impairments that you mentioned, right? So malingering is something that is very rare, which is, if having all these symptoms just to have additional gain, it maybe, get an advantage of your grades or whatever. That's very rare. I mean, we tend as a physician to always trust the patient and listen to the patient's symptoms.
Well, I think we're going to conclude and just want to really thank all of our panelists and attendees for such a robust conversation about long COVID. That was really insightful. And thank you all. And we'll have this recording available in the future. And thank you, Dr. Goltz, for joining us from outside of Nashville, zooming all the way in with us. So thank you all and have a great day.
Thank you for having me.